Now starting. All attendees are in listen-only mode.
Hello, this is Joe Burke, and on behalf of ISQua, I would like to welcome you to today's webinar with Alana McMahon. Alana is a senior consultant in PwC in Australia, and today she'll be talking about traceability of surgical instruments. Alana's presentation will last approximately 20 minutes, and then we'll leave 10-15 minutes for any questions you might have. You can ask questions at any time throughout Alana's presentation by typing them or raising, raising your hand. I hope you enjoyed the webinar. Over to you, Alana. Alana, over to you.
Okay, so let's say imagine, yep, can you hear me? Okay, so let's say imagine you go home today and you turn on the news and you see that a stadium of 100,000 people have died. What would you think? It's a shocking number, isn't it? This is the number of people that die every single year in the United States from hospital-acquired infections. It's a shocking statistic, and it's partly the reason why I took part in this study. So there's 3 topics that I'm going to cover today. So understanding the challenge, a potential solution, and the benefits realized from this solution. So I'm sure each and every one of you on the line has had close friends and family members go to hospital. But unfortunately, hospitals can be dangerous places, with approximately 10% of patients contracting hospital-acquired infections. So this results in higher costs for hospitals, litigation costs, additional care for patients, and a higher chance of mortality for the patient. The UK alone spend £1 billion every year combating hospital-acquired infections, and the US spends $5 billion every single year. So I decided to focus my study on hospital-acquired infections, and more specifically on surgical site infections. So this graph was conducted by the HSE, which would be the equivalent of the NHS in the UK and NITA in Australia. So this shows that surgical site infections account for almost a quarter of hospital-acquired infections. So they're just as common as urinary tract infections. So there are 3 ways in which patients can contract a surgical site infection. Firstly, this would be through airborne dispersal, so from microorganisms in the air getting into the patient's wound. Secondly, self-contamination, so it's bacteria on the patient's skin getting into the wound. And thirdly, through direct contact. So this is either through the surgeon or from contaminated surgical instruments. So surgical site infections can occur as a result of an inadequate sterilization process, but they can also result from not having a traceability solution in place. So in 2002, a patient in the UK walked into a hospital with CJD. This is more commonly known as mad cow disease. So this patient underwent surgery in the hospital, and it was only discovered during the brain biopsy that the patient had CJD. So at which point the surgical instruments were back in circulation in the hospital. So the hospital didn't have a traceability solution in place. So all patients that had undergone surgery that day in the hospital had to be called back to be told they could potentially have contracted CJD. So this is giving stress to 24 patients, unnecessary stress. And also because they couldn't identify which surgical instruments had been contaminated, they had to destroy every single instrument in the hospital because CJD cannot be sterilized and removed from instruments. So this was £90,000 worth of instruments destroyed. But thankfully, I suppose, CJD is not that common. But another case, which would have been more widespread, was another hospital in the UK, and hopefully this won't put people off going to hospital in the UK, but 83 women went in for surgery in hospital. And it was only discovered a few months later that the sterilization process wasn't working correctly. The autoclave was set at an incorrect temperature, so the instruments weren't getting sterilized properly. So 83 women who had undergone surgery had to be called back to be told that they were at risk of cross-contamination. So obviously from this you can see that patients are at major risk from surgical site infections, and it would require a lot more time from physicians to deal with these, re-examining patients. So going back, we've looked at hospital-acquired infections causing harm to patients, and we've also looked at this requiring additional time from physicians. So there's also laws which hospitals must abide to. The HSE, again, which is equivalent to the NHS or NITA in Australia, state that systems should be implemented in decontamination units in hospitals. It also states that instruments need to be linked back to patients to verify which instruments were used on individual patients. It also states that instruments need to be tracked at every step in the sterilization process. And it states that records should be kept of all the sterilization cycles and the autoclave cycles. And these regulations also state that instruments need to be marked with GS1 barcodes. So essentially we're saying that without a traceability system, hospitals are not compliant with their national guidelines. In Scotland, the Health Protection did a study which found that only 17% of hospitals were complying with their national guidelines. So what's the solution for this? So basically we need a solution to tackle the problem of causing harm to patients, requiring additional time from physicians to treat the patient, and also a solution which complies with your national standards. So the solution proposed was a traceability system for surgical trays, more specifically surgical instruments. So there's 7 stages to the decontamination process, and as you can see here on the slide, it starts off in the washroom where the instruments are manually washed. They're then put into the disinfected in the washing machines. They're then left in the clean room to be dried and wrapped up in sterilization paper. At which point they're put into the autoclave for sterilization. And they're then left in the cooling area and then stored in the sterile store, where they're ready then for theatre use. So there's potential weaknesses within the current process. An initial manual wash could be missed, or the wrong settings could be on the washer and the autoclave. So the pilot project in Ireland introduced pieces of software to demonstrate that surgical instruments are sterilised successfully. So you're probably wondering how did this system work? So the surgical trays were barcoded and scanned at each step of the 7 steps. And the set is then scanned into theatre so the instruments can be tracked back to the patient. So this traceability ensures that each step is completed and there is a history kept of the set, and then this can be traced back to each patient. You can see here on the slide the image on the right, the small image, that's the independent monitoring system. This is linked to the washers and the autoclaves. So it ensures that the correct temperatures are set for the washer and the autoclave, which wouldn't be in place if the system wasn't there. So due to economic pressures, many hospitals loan surgical instruments from commercial lenders and also from other hospitals. So say for example in Ireland we loan instruments from the UK and also from France. So it's important again to have that traceability there, that you know where the So 8 hospitals in Ireland have currently implemented a solution. So I suppose if we just stop for a minute and just ask, has anybody heard of GS1 before?
We're just gathering all the data, and I think it's finished now, so here are the results. "57% say yes and 43% say no."
Okay, that's a good result, because before when I've asked this question, literally one person out of a room of 20, 30 people might have heard of GS1 before. Jolanta, would we be able to go back a slide, please?
Jolanta, would we be able to go back a slide, please?
Absolutely.
Thank you. So,
Thank you. So,
I suppose to understand, GS1 standards. So if we think about what happens when there aren't any standards, say for example, take shoes. So in New York, you might have a size 7 is the equivalent of a size 38 in Shanghai, because there are no standards for shoes. So manufacturers have to mark the same shoes differently depending on what country they're being sent to. So standards enable clear exchanges between organizations. So GS1 standards are open and compatible. You're not locked into a proprietary solution because GS1 standards are interoperable and compatible with many technology solutions. They're used globally. So when tracing instruments across borders, hospitals can use GS1 barcodes to identify instruments in any country. And they're proven and tested. So GS1 has been around for over 30 years and it's widely used in different sectors globally. And also importantly, they're simple to use. So anyone in the supply chain can use GS1 standards. So at this point, we tried to look at the potential cost saving of this surgical tray solution. So unfortunately, it's still too early to tell if surgical site infections can be reduced from the implementation of this system. But however, the potential cost benefit is very high. So if we take in this example, an average hospital carries out 14,000 surgeries a year, and we're saying that 5% of these surgeries results in a surgical site infection. So another study in Ireland showed, and this is almost partly why this system was implemented, that 1/3 of surgical site infections are directly related to contaminated surgical instruments, and this is massive. So if we look at this diagram and we're saying that 5% of these 14,000 surgeries resulted in infections, and even if we take, not even 1/3, even if we reduce that down, if we take even that 10% of these surgical site infections are related to contaminated instruments, you're looking at saving €1 million each year. So the cost of combating surgical site infections for an average hospital in 1 year is just over $1 million. The first year to implement this system costs $100K, and that's just an initial fee, and the following years there's a €12,000 maintenance fee. So you're looking at saving over 100 million, and this is being conservative, over 100 million in the years following implementation. So there's a massive potential cost saving here. So I suppose where to from here? I suppose we've delivered this presentation in Europe and in Ireland, and the feedback has been very positive. I think so. Basically, it's trying to get the message out there to encourage other hospitals globally to use this system, and especially if we're loading instruments from one hospital to another, this will become more beneficial. So currently, this hospital will be rolled out in a further 29 hospitals in Ireland, and ideally, we want to get to the point where the surgical instruments are marked individually. So there'll be laser-etched barcodes on each surgical instrument. And ideally, this should happen at the manufacturer stage. So I'd like to just finish up and say that we would love to see everyone else consider this solution and maybe spread the word more about GS1 standards. So thank you. And please, if you have any questions,
That's it, Alana.
feel free to ask any questions now.
Great, Alana. Thank you very much, Alana. We already have one question from Vanak Shrun asking, what are the main causes of surgical tray infection?
The main causes of, say that again?
The main causes of, say that again?
What are the main causes of surgical tray infection?
Surgical site infection.
Surgical site infection.
Tray infection. T-R-A-Y, tray.
Okay. So
yeah,
okay.
What are the main causes of surgical tray infection?
I'm going to interpret that question.
I'm going to interpret that question as a surgical site infection.
Correct me if I'm wrong. Correct me if I'm wrong.
Vanak, let me just see. Just let me try and allow Vanak, Vanak, can you hear us? Hello, Vanak, can you hear us?
Yeah. No, I
Could you
cannot
please
hear.
clarify your question? Could you please clarify your question, Vanak?
I cannot hear.
Would you be able
Okay,
to
so right now
clarify
I
your
got
question
your
for
voice.
Alana,
Right
please?
now I got your phone.
Okay, please read the slide, but I don't know which slide number. They talk about the topic of traceability, traceability solution for the surgical trace. So I would like to ask this: is the main which is the main cause of the transmission by surgical trace? Surgical trace. You hear me?
There's some feedback there in the mic.
There's some feedback there in the mic. Yep.
It's difficult to hear.
Yeah.
It's difficult here.
Okay. What I'll do is I'll send Alana the question by chat, and we'll move to the next question. Thank you, Vanak. We'll just come back to your question in a few minutes.
Okay.
And Tom Collins, over to you. Tom Collins. Hello, Tom. You wanted to ask Alana a question?
No, I'm good. I don't need to ask a question.
I'm good. I don't need to ask a question.
Okay, that's great. Thank you. We have a question from Dina Barudi. Thank you very much for the nice presentation. Do you have any data on the relation between SSI and proper antibiotic prophylaxis?
I don't have any information personally myself on that. On that, but we can have a look and maybe send something through after the call.
Great. And a question from Caroline Connolly. Can you tell me the reference for the Irish study that identified that 30% of surgical site infection was related to contaminated equipment?
So this study was carried out by sorry, there's feedback on the mic. This study was carried out by a member of the HSC in Ireland. Unfortunately, the study is unpublished. You can partly understand why the study would have been unpublished. I tried for months to get in touch with the nurse who conducted the study, but no joy. So we don't have that online. I mean, the study has been done, but it hasn't been published. Can you hear me?
Yes, we can hear you very well. Thank you very much, Alana. I just sent you the question from Vanak Sharon.
Okay, so what are the main causes of surgical site infections?
Surgical tray infection.
As much as I can say, we've just broken it down into three different ways. So firstly, from microorganisms in the air. This is just bacteria in the air circulating around in the room. And when the patient is cut open, these organisms can get into the room. Studies have shown as well that the more people that are in the room, the more likely a person is to get a surgical site infection. So the more people, you know, it would be literally impossible to pinpoint, I would imagine, exactly how that infection was caused. But you can do studies to show, okay, it's more likely caused if there's more people in the room. If the instruments haven't been sterilized, that's going to cause an issue. And there's certain ways to ensure the room is completely clean before surgery takes place.
Okay, that's great. Thank you. We have another question from Cliff Hughes. Thanks, Alana. What can we do about the trends to move trays from hospital to hospital? For example, implant kits for orthopedics with myriad screws, etc.
Can you repeat that question? It's difficult to hear.
Certainly. What can we do about the trends to move trays from hospital to hospital? For example, implant kits for orthopedics with myriad screws.
To move trays from hospital to hospital. So are you referring to like trays being loaned from hospital to hospital?
Cliff, let me just... Cliff, can you hear us?
Yeah, can you hear me?
Cliff? Yes, we can hear you now. Could you clarify your question, please?
Yes, there's a trend, at least in Australia, for surgeons to take trays from larger hospitals to smaller hospitals, and particularly when they've got an implant kit around, say, hip replacement with myriad of plate screws and other accessories. How do you think we can manage that using your suggestions?
Well, do you mean just to manage the traceability of these trays moving from the bigger hospitals to the smaller hospitals?
Yeah, correct.
Yeah. Well, I suppose if this system is in place, what you would do is you'd have that system, you'd have the GS1 system implemented in both the large hospital and the smaller hospital. So all the information is stored in a server. It's called the MS1 server. So when the system is implemented and each of the surgical trays are barcoded, so in the large hospital, when the tray is moving to the smaller hospital, it would be scanned out of the larger hospital, and this will be recorded up in the server. So then when the tray arrives to the smaller hospital, you'd scan the tray into the smaller hospital. So then you have perfect traceability of where the tray has been. So then at each point during the decontamination process, this tray would be scanned after each step in the decontamination process in the smaller hospital, and it's then also scanned to the patient. So when the tray is ready to be brought back to the larger hospital, it would be decontaminated first, scanned out of the smaller hospital, brought to the larger hospital, scanned in, and all of this has been recorded. All of this data has been recorded in the database in the server. So you can see which patients have used this tray in the smaller hospital and at what dates, everything. The cycles, all the detail will be there. It's a case of having that system implemented in both hospitals.
Certainly I understand that, but I was thinking about the complexities of some of these trays with literally dozens and dozens of components. Would each of those have a separate barcode, or would you do it as a barcode per tray?
Yeah, so what we've started off, the way we started in Ireland was we barcoded the tray. Right. And which took some time, it took a few months for the hospitals to do this. You'd have a barcode in the tray, and then when you're scanning that barcode to the system to begin with, you'd have to put in all the detail of what's in that tray. I mean, the intention is, to be scanning individual items, but maybe for that situation where there's so many tiny individual items, it might be better just to, in the first instance, scan it as a tray, and then it's just important that all that stays within the tray, and checklists are done. Part of the process is to look at the checklists and ensure that everything there, all the items are there in the tray. And one benefit of the system is that when you scan the tray, once that checklist is done once, it's up there in the server. So when the tray is scanned in the smaller hospital, a checklist is printed automatically showing exactly what should be in this tray. So someone will be there checking to ensure that all items are there in the tray.
Okay, thank you.
Thank you, Cliff. We have another question from Carter. Are there any plans for follow-up studies? Anna.
Can you repeat that, Jolanta? Please?
Sure. Are there any plans for follow-up studies?
Not that I know of at the moment. I know that Ireland are really progressing with implementing the system. France have implemented the system in a hospital, so the UK. And from speaking with people in Europe, there are considerations of implementing the system further around Europe and also in Asia. So I would imagine that a second study, another study will be done to follow up on this. Not that I know of yet, but I imagine this study started because GS1 approached Trinity College in Dublin and asked the students to do the research. So I imagine they will do this again once it's fully implemented.
Okay, that's great. Another question from Dina Varodi. Do you recommend that the instrument will be washed in the operating theatre or brought immediately to CSSD without washing?
Is the question that Should the instrument be washed?
That's right.
Is that the...
That's right. Would you recommend that the instrument will be washed in the operating theatre or brought immediately to CSSD without washing?
I see what you're saying. So I don't know if there's a specific recommendation for this, but how it's done, as I know it, is the instruments are used in the operating theatre. They're then left outside the operating theatre, and a porter brings these to the washroom. So they're not actually washed until they get to the CSSD. However, the washroom should be in a separate, the decontamination unit should be divided into two. So you should have the washroom separately cordoned off from the sterilization area. So they'd be hand washed in the basins and then brought to a separate room for sterilization in the clean room.
Okay, great. Thank you very much. We have a couple of other questions. Roisin Boland asked if a follow-up study is planned, but you responded to it already. And Martin Canova had a question: is there traceability solutions that are currently implemented, and if so, has it reduced infection rates?
Well, I suppose that's...
Did you have more data
a good question,
on this? Mm-hmm.
Very good question. But unfortunately, it's too early to tell if surgical site infections can be reduced by this system. But if you look at studies and the case studies that I introduced at the beginning, where patients were getting infections because the autoclave was set at the wrong temperature. So there's a lot of different parameters that can be set wrong in the sterilization unit, and if these aren't set correctly, the instruments are not sterilized properly. So it goes without saying that this completely ensures that instruments are contaminated correctly, because every single step of the process is tracked and ensured that no step is missed, and that, like I was saying, the independent monitoring system, which is linked to the autoclaves and the washers, that ensures that the temperatures are correct, and the sterilization cycle will not be passed unless these temperatures are met. So to answer your question, I'm fully certain that surgical site infections will be reduced, and the Irish study found that a third of surgical site infections are related to contaminated instruments, but I'm sure that's probably being conservative as well.
Thank you very much, Alana. Your presentation has definitely raised a lot of questions. I have one more question from Piringar Mercy Nyang. I am just wondering how I can replicate this study here in Nigeria, where most maternity clinics use very crude methods of sterilization.
Okay, well, I would say firstly, I would recommend contacting the nearest GS1 office to Nigeria. I can check that out and give you the details after the call. GS1 offices are located globally, and this is what they do. This is their bread and butter. This is standardizing and traceability systems is what they do. So they would be very keen to help you out, I'm sure, if you were to contact your local office. Obviously, if you do want any more information from the research that I have done and on the recommended sterilization processes, or even the processes that they currently use in Ireland, I'm happy to send these on to you as well for best practice.
That's great. Thank you very much, Alana. And thank you for your presentation. The copy of this presentation, the copy of the webinar will be available online within the next 24 hours with some extra reading material for everyone. And thank you to all the participants for your attendance and your questions. And Alana, once again, thank you very much.
Okay, thank you everyone, and thanks for listening.
Goodbye.